Okay, so as per Musin's presentation, there's quite a lot to get through, so I'll try and move through quick things relatively quickly. But please shout out or leave the questions to the end, so we can go through things. Okay, so these are the learning points, what we hope to achieve during this half-hour session. To talk through the quickly, I know Musin's talked about this, but the pathologies of some of the common hemoglobinopathies, some of the novel therapies which Musin alluded to, stem cell transplantation and where we are regarding that in sickle cell disease patients, and gene therapy, which is one of the more exciting, they're all exciting, but one of the more exciting new therapies in sickle, and what we have available as far as clinical trials, mainly sickle actually, unfortunately, not a great deal in thalassemia. But I will start with thalassemia and just briefly talk about the thalassemia syndromes. So just to orientate you all, I'm sure you all know this, sort of there are two alpha, two beta globin chains in adult hemoglobin. In thalassemia, the issue is of a quantitative defect in one of those chains, either alpha or beta, and as a consequence, there's an excess of the unaffected globin chain. This results in hemolysis. If this occurs in the peripheral vasculature, it's called extravascular hemolysis. However, if it occurs within the bone marrow niche, then it's referred to as sort of ineffective erythropoiesis effect in essence. Alpha thalassemia tends to occur as a result of large deletions. Now, where that deletion occurs, where it gives rise to the clinical phenotype, and if the deletion in itself causes results in a residual alpha globin chain production, then it's called alpha plus thalassemia. However, if that deletion results in a complete sort of abolition in alpha globin production, then that's alpha 0. So there are four sort of clinical, three clinical phenotypes as a result of four different mutational states. And that's it sort of gives rise to the severity of disease. So on the left, when you have either one or two of the alpha thalassemia genes deleted, then that gives rise to alpha thal trait. When there's only one remaining alpha globin gene, then that gives rise to an intermediate phenomenon known as HBH. And when all four genes are mutant, then that gives rise to hemoglobin Barts. Hold on. There we go. So the alpha thal traits, depending on whether there's any modifying factors and the number of mutant genes, gives rise to a relatively mild clinical phenotype. And most patients may have a mild hyperchromic anemia, but clinically aren't really all that affected by disease. It does have implications. They do need to be regularly monitored. Well, some of them do need to be regularly monitored. And from neonatal screening perspective, it's quite important. HBH, this intermediate disorder that I referred to, gives rise to a more severe phenotype, and it's quite variable in the way in which these patients present. But most of them don't require transfusion, but they do need close monitoring. HBH is the extreme end of the spectrum. These patients don't produce any alpha chains, and as a consequence, don't produce any adult hemoglobin. And without early intervention and transfusion in utero, then it is almost universally fatal. As for beta thalassemia, the genetics of these slightly different in that the mutations occur as point mutations. So as opposed to these relatively large deletions you see in alpha thalassemia, tend to see smaller point mutations. And again, depending on where that mutation occurs, determines whether an a beta naught, sorry, i.e. they produce no beta chains or they're a beta plus. Thankfully, we rarely, if never, see these sorts of patients anymore, these sort of pictures anymore. But these are illustrations of the extramedullary hematopoiesis that occurs in those patients who have transfusion dependent or thalassemia major. Now, these patients nowadays, as I said, with the transfusional programs that are in place, we tend not to see these sorts of complications. Now, effectively, there are three things that we look out for in these patients, and it's mainly in relation to failure to thrive as opposed to anemia. The hemolysis can give rise to implications in relation to risk of infections and the effect on the vascular endothelium by depletion of nitric oxide and iron overload, either as a consequence of the disease itself with the rampant hemolysis, but also in those patients who are heavily transfused, they become iron overloads because of the iron burden of the blood and require regular monitoring to limit complications as listed on the slide. So, as I alluded to earlier, blood transfusions is the cornerstone of therapy, and we have a hemoglobin target around about 95, depending on the patient, to reduce the complications that I've alluded to and are listed there. Iron overload, as Musin's already sort of described, is managed with one of those three agents, and patients require regular monitoring. In this patient group, in the pediatric setting, bone marrow transplant is really the only curative therapy. Not available for adults routinely. There is this relatively newly described phenomenon, sort of described probably about, well, not probably, about 10 years ago by David Weatherall in Oxford, which describes a patient who isn't transfused but requires chelation because they become iron loaded and they have other complications of disease which require close monitoring and management, things like extramedullary hematopoiesis and the other things that are listed on the slide. And these are the patients like the HPH, which I've talked about earlier, and some of these other two, which are effectively milder forms of beta thalassemia. They have risks of the complications that are described in relation to the transfusion-dependent thalassemics. However, these tend to be milder, and thankfully they don't suffer the sequelae of those that are transfusion-dependent. This slide really wants the main point of the slide is to illustrate the complications, but also to highlight that in most patients, the focus isn't on saving life. It's more about managing disease complications, particularly iron overload, and and compliance in this arena is often a bit of a challenge. We need your support in those patients. So, sickle cell disease. I know that Musin's talked about this at length, so I'm not going to labour it if I'm honest, but again, here's the adult hemoglobin. Here it's a point mutation that Musin's already described, which gives rise to a change in the amino acid sequence. And this illustration, effectively, what it was trying to do is sort of split out the various elements of the pathophysiology of sickle cell disease. which Musin has talked about. So I don't feel that I need to talk about it in any great detail, but just to highlight that there is definitely there's good evidence to support that sickle cell disease is a very inflammatory disorder, and this inflammatory process does have sort of implications for management, and which I may allude to, or I may talk about later in relation to transplantation. Again, Musin's gone through this, so I won't labour it, but pain is only really the tip of the iceberg in relation to sickle cell disease. It's a multi-system, multi-organ disorder. So Fred Peel created this very nice illustration to show the breakdown of the various organ systems and how they are impacted by sickle cell disease. You're pretty hard pushed to identify an organ which isn't impacted by the disease, unfortunately. So currently, we are relatively limited on our treatment options, well, up until recently, and this has impacted on the survival of patients with sickle cell disease. It's quite disappointing, or quite concerning that not too long ago, the mortality of sickle cell disease patients was less than 50 years. Thankfully, this has improved to 67, but this is still about 16 or 17 years lower than their age-matched peers. So there is still quite a lot of work to do. As you can see from this illustration, that certain drug interventions and public health interventions have impacted on the way in which disease is managed in a positive way. So hydroxycarbamide, again, I'm not going to labour this because Musin's already talked about it, but this is one of the cornerstones of current therapy. And again, he's talked about this, so I'll just move through it because I know we've got quite a few slides to get through today. Transfusion is the second one, and there's going to be offered either as top-ups or as exchange transfusions, and each has benefits and challenges, some of which are listed on the slide. So this is really where we get into the meat of the presentation, the novel therapies in sickle cell and thalassemia. So crizanlizumab is the first drug. It's a monoclonal antibody which targets an adhesion protein called P-selectin. Now, this adhesion protein is responsible. So so in sickle cell disease, that adhesion protein is prominent and gives rise to the interaction of the vascular endothelium with the sickle cell, but it also impacts on the interaction with platelets and neutrophils as well. And the theory is that if you can ameliorate that interaction, then you can modify sickle cell disease and its downstream implications. So crizanlizumab was studied initially in several trials. The most pivotal of one was the SUSTAIN study, a phase 2 multi-center trial that looked at patients who had a severe sickle phenotype and had several vaso-occlusive crises over the course of a year. Now, the main endpoint for this study was the incidence of painful crises, vaso-occlusion. They were given a monthly infusion of this drug, and probably the most important outcome slide is this one, in that those patients who were not on hydroxycarbamide was allowed during the study, and those who were not on hydroxycarbamide had a 50% reduction in the number of crises they experienced. And not unsurprising, those who were already on a disease-modifying agent had a slightly reduced but not insignificant impact with this particular therapy. So the conclusions from those studies was that it's a very effective drug at reducing the number of crises, very well tolerated with few side effects. It's a monthly infusion which has its issues, particularly with some of our patients who have access problems, venous access problems. And at the moment, we have this drug available to us in a managed access program. Now, there are ongoing trials to assess the effectiveness of this particular agent in other complications of sickle cell disease, particularly renal disease, priapism, and because the trial only looked at 16-year-old candidates and over, there's a trial looking at a slightly younger group of patients. The second agent is voxelotor, or GBT440, as it's sometimes, well, as it was previously assigned. This drug works by stabilizing, well, it binds to the alpha globin chains of the hemoglobin molecule, or hemoglobin, and what it does is it shifts the oxygen dissociation curve. So it means that sickle hemoglobin, which is a low affinity hemoglobin, so it releases its oxygen very readily, makes it slightly less so. So if you recall from those early slides, it's a deoxygenated sickle hemoglobin that is particularly problematic. That's when a polymerization occurs, and that's when all the downstream problems tend to be experienced. So if you can limit that deoxygenation, then you can ameliorate disease. And this is how this drug works. This was assessed in a phase 3 trial, the HOPE study, which had very similar inclusion criteria to the SUSTAIN study for crizanlizumab. But it focused more on an increase in hemoglobin and reduction in hemolysis, though one of its secondary endpoints was to look at the incidence of vaso-occlusive crises, the annual incidence of vaso-occlusive crises. It's a tablet, which does have its certain advantages over the other drug that I talked about. And really the summary of this slide is that it again is very effective at reducing vaso-occlusive crisis, but also reducing the hemolytic markers. One of the endpoints was a hemoglobin rise of 10 grams within the first 28 days. It achieved that in the vast majority of patients and was very well tolerated. Very few side effects compared to placebo. So it's all well and good looking at the trial data, but this is some US real world, as they describe it, data on voxelotor. It showed, as I sort of suggested from the previous slide, an increase in the vast majority of patients in hemoglobin by at least 1 gram, by 10 grams per liter. A reduction in the number of transfusions for these patients by more than 50%, and a reduction in the number of vaso-occlusive crises. So ticking a lot of boxes. So it obviously has significant advantages over a parenteral agent, as it's very easily administered as a tablet. There was a managed access program for this drug, which has now closed, and we hope to hear from NICE over the early next year. And the general feeling is it's likely, though we can never tell one from NICE, but it's likely this agent will be authorized for use. Again, there are ongoing trials to assess other elements of other complications of sickle cell disease, in this case mainly related to cerebral function, neurocognitive function. They had a lower age cutoff of 12, so they've gone down to trialing this in 4-year-olds now. And they are also looking at this in relation to leg ulcers. Leg ulcers occur because of vascular, in the main due to vascular damage and nitric oxide depletion. So if you can avoid vaso-occlusion and also reduce the the nitric oxide depletion, and as a result of preventing hemolysis, then the hope is that that will significantly help with leg ulcers, which are extremely difficult to manage in sickle cell patients. And a subgroup analysis from the earlier trials does suggest that actually it's really quite effective in that particular problem. So very quickly talk about stem cell transplantation. So this is really the only curative therapy available to us in sickle cell disease patients. It was commissioned after some time of debate with the commissioners, but finally commissioned in 2019, just before COVID hit. But unfortunately, there was a big hiatus before we were able to start transplanting adult sickle cell patients. It's unfortunately not the panacea, because the vast majority of patients with sickle cell disease do not have a full sibling match. The American data suggests between 16 and 18% of children, that's where most of the trials are done, have a sibling match. And unfortunately, the commissioners have only allowed us to do fully matched siblings. So for most patients, it's not going to be a treatment choice, or treatment option, I should say. And the patients that will be selected are those that have significant comorbidities that are life-limiting, and other treatment options aren't really available. So at the moment, so the previous data did suggest that this is a really effective therapy, improving quality of life, survival. The frequency of hospitalization dramatically falls, as does opioid use, and was a really well-tolerated intervention. We at Imperial are in the final throes of sorting out our pathways and protocols, getting our first transplants, and we hope to do our first transplant in the next year, in the coming year. As for what's available from a clinical trial perspective, this is a list of our active trials in sickle cell disease and thalassemia. Sort of want to orientate you to these AG trials using a drug called mitapivat, AG348, which was initially designed for another red cell disorder, which I'll talk about a bit later. Well, a bit later is right now. So mitapivat is a drug that was initially designed in the treatment of pyruvate kinase deficiency, which is an enzyme disorder in enzyme disorder in a red cell enzyme disorder, I should say. And basically what this drug does is it binds to a site other than the active site of the enzyme, stabilizing the protein and increasing its survival within the red cell, and therefore increasing levels. So the Agios, the company that designed the drug, realized that there may be some additional conditions that they could use it in. So on the left, you see pyruvate kinase deficiency, very effective at reducing or ameliorating that particular disorder. But they also noticed that, and their early animal studies showed it was very effective in treating hemoglobinopathies, alpha, beta thalassemia, and sickle cell disease.
Speaking.
Sorry?
Oh. Sorry, if you go on, Stephen, I think
okay.
someone is off mute. I'll have a look.
Okay, thank you. So at the moment there are they are in the, as I alluded to, they're in the late throes of the regulatory process for PK deficiency, and in the late sort of they're now in phase 3 clinical trials in hemoglobinopathies. So the Energize trial is a trial in alpha and beta thalassemia in patients who are non-transfusion dependent thalassemia, and the Energize T for the transfusion dependent thalassemics, And the Rise Up trial is in sickle cell disease patients. All of these trials are open in Imperial, when we are actively enrolling patients to the particular trial, to these particular studies. Now, it's the sickle cell story is probably the more interesting one with this particular disorder. So this is the glycolytic pathway, and I've only got 5 minutes left. I need to move on. So effectively, what you're trying to do is you're trying to increase 2,3-GPD and increase the net production of ATP, and by doing that, you can then shift again. 2,3-DPG is important in managing the oxygen dissociation curve. So if you reduce 2,3-DPG, you actually increase oxygen affinity of the sickle hemoglobin. So very similar to voxelotor, the drug that I described before. Very well tolerated. The early study suggested, very small numbers, but suggested that it increases hemoglobin by at least 10 grams per liter. And side effect wise, very few side effects. The majority relate to the effect it has on aromatase, and therefore the impact on triglycerides, sleep, and that's mainly it. So in the last few minutes, I'm going to quickly whiz through gene therapy. So gene therapy is either to ameliorate disease by inserting a new gene, or by turning off a defective gene, or by correcting the gene defect. So here we are trying to increase fetal hemoglobin. Basically, this is the way in which intervention works at the moment, is to increase fetal hemoglobin production. And because fetal hemoglobin does not contain beta hemoglobin, which is problematic in sickle cell disease, it means that the disease is modified in a positive way. And this basically talks about the hemoglobin switching, which I won't bore you with. So this slide really tries to further illustrate that point. BCL11A is a genetic switch, and the binding of BCL11A occurs in the late fetal stage, switching from gamma globin chain production to beta globin chain production. And in a sickle cell patient, that means the production of sickle hemoglobin. However, if you can interfere with that process, interfere with the binding of this this genetic switch, then what you can do is it will revert back to the production of the gamma globin chains and therefore fetal hemoglobin. So that's really just an illustration to say that exactly what I've said. So the gene editing process, the stem cells are collected from the individual, relatively straightforward process. They are modified ex vivo while the patient is prepared with conditioning, which is currently busulfan, and then those cells are after they've been modified, the alteration as I described is made to the genetic code. Then you reinfuse those stem cells, which find their way back to the bone marrow niche and hopefully have a positive impact. So CTX001 is the proprietary CRISPR-Cas9 product, which effectively is a genetic cut and paste process where you disrupt that binding site for this genetic switch, and now has a proprietary name of exa-cel. The first 2 trials were really quite effective in both thalassemia and sickle cell disease. In this case of the thalassemics, the CLIMB 111, it was transfusion-dependent thalassemics, and it by increasing fetal hemoglobin, you significantly increased total hemoglobin to near normal, if not in many cases, normal levels. And all patients, granted, those initial studies were relatively small numbers, but all patients were transfusion dependent within 3 months. Climb 121 was in sickle cell patients, and similar results in that they were able to cause a dramatic increase in fetal hemoglobin, and as a consequence, those relatively small numbers, all those patients became transfusion dependent. So really durable results, durable engraftment, significant rise in fetal hemoglobin, and few side effects. So I can talk about the actual side effects a bit later. I'm not going to, we can have a look at those later, but effectively in this slide, this illustrates, so these are all individual cases. So they're all relatively small numbers. So only about 74 patients worldwide have been exposed to this particular intervention in this iteration. And the vast majority of them are have had sort of very positive outcomes with a significant rise in hemoglobin. And in the case of the sickle cell patients, have had a almost complete, if not complete, reduction of vaso-occlusive crisis, or absolute elimination of vaso-occlusive crisis. So there are ongoing CLIMB studies assessing this particular intervention, and all the patients doing the early studies have now been recruited into this long-term follow-up. I think they're following up for 15 years. This is CLIMB 131. And then there are a couple of other studies looking at even younger patients in sickle cell and thalassemia. And though there were some unfortunate side effects, a couple of patients, one patient had HLH, another patient had a delayed engraftment. Thankfully, all of those recovered successfully. But yeah, the data so far is very, very good. So this intervention has now gained orphan drug designation, so it's going to be fast-tracked through the FDA, and it's been granted sort of a rolling assessment status. So the hope is that we'll get a final decision from the FDA early next year. And this is the list of the upcoming trials that we should have available in sickle and thalassemia, well, actually mainly in sickle in Imperial. So life expectancy has improved over the last few years, last 10, 15 years, but it certainly can do much more. Previous therapies have showed limited effect on disease and modification of disease. New existing therapies are showing more promise, and I hope that more of these drugs are available, and that will continue to improve mortality and morbidity. And allogeneic stem cell transplant is an option, but for a very new group of patients. What is exciting is gene therapy, and that should be available to us fairly soon. Thank you, and apologies
Excellent.
for being late.
No, that's fine. Thank you so much. We're going into a break now, but before you go, there is a question here from Dr. Zada. He said, what sort of HB increase is it voxeloton treatment, and where does this drug get metabolized, knowing that sickle cell patients are likely to have comorbidities such as liver and kidney? Thank you.
So the trials showed in, I think it was over 90% of patients, there was an increase of hemoglobin by 10 grams per litre, and in a smaller cohort, and it was sort of an incremental rise, and in a smaller cohort of about 20%, it was an increase of up to 30 grams per litre. Now, as for its metabolism, it's metabolized predominantly in the liver. However, having an excess of drug isn't a particular problem, in that it binds, its predominant mode of action is to bind to the alpha globin chain and stabilize the protein, the hemoglobin. So there's only a finite binding site for this agent to reside. So there haven't been any recorded issues for those who have significant renal impairment. But when the drug does become fully accessible to us, we will assess those patients on an individual basis before prescribing.
Lovely. Thank you so much. Oh, there's a follow-on. What sort of hemoglobin? There's a follow-on question. Yeah, that was the following question from Dr. Zada. Sorry, what sort of hemoglobin?
So you mean the increase in hemoglobin because it's fetal? Sorry, it's not fetal hemoglobin. It's sickle hemoglobin. Because effectively, what it does, it binds and stabilizes the hemoglobin, and it stops hemolysis. So it doesn't, unlike some of the other interventions, which cause a change from sickle hemoglobin to fetal hemoglobin. This is sickle hemoglobin. It's actually altering and stabilizing the molecule and stopping it from breaking, or the hemoglobin and stopping it from breaking down. So this is sickle hemoglobin that's sort of persisting longer effectively.
Wonderful. Thank you so much,
There's
Stephen.
also one more question just from Dr. Lisa Anderson.
Okay, I didn't see that one.
Dr. Lisa Anderson has asked, have you dealt with HbF genotype and what this means for interpreting not only the FBC but also the HbA1c?
So can you say that again?
She said, have you dealt with HbF genotype and what this means for interpreting not only the FBC but also the HbA1c?
So if this is in relation to sickle cell patients, the fetal hemoglobin that's elevated is actually beneficial, aids amelioration of disease, as I've alluded to in the presentation. As for in relation to interpretation of HbA1c, assessing HbA1c in sickle cell patients, all hemolytic anemias is actually quite difficult because the hemoglobin has a shorter half-life. It only lasts about half-life. It only lasts about 10 days. So HbA1c isn't the most effective thing to monitor in patients with hemolytic anemias. There is some suggestion fructosamines are beneficial, though there is recent data to suggest that fructosamines aren't that helpful. However, it's a relatively reasonable screening tool. Unfortunately, the vast majority of these patients, so there is a suspicion that they may have diabetes or diabetic state, need to have oral glucose tolerance tests. And we've had to do that with a few of our patients because that's the only way at the moment of properly assessing patients who have hemolytic anemias, who also either have diabetes or we're concerned they may do.
Thank you, Stephen.